Can we say that you have more pain on the right side or more on the left side?
Left.
It's more on the left. And does it go down the shoulder?
No.
Does it propagate down to the finger, something like this?
No.
No. So it doesn't look like a neurological symptoms, but still we have to check. Can you? Yeah, this is good. I just need a little bit more space. So first, you can check the active range of motion. I'm going to start directly with the passive range of motion because we have to check and to see which part of the cervical spine is involved. Of course, you can go lower with the thoracic spine, and usually I check first the pelvis and I go up, I check the lumbar, thoracic, and I go to the cervical spine. So in general, we check the rotation, so we make a very gentle, we check the rotation to the right and we check the rotation to the left. And here they seem the same, we don't have a big difference. And then in my country we go to check the upper and the lower cervical, so we make a complete flexion of the head. And from this position I try to see, this is the rotation to the right, and this is the rotation to the left, and the rotation to the right is worse than the rotation to the left. I don't know if it is visible for you. This is the rotation to the left, and here we have a stop. And we have a big difference between the left and the right rotation. And we make an extension. Here we go low, we go to a lower cervical, and we check again the rotation to the right. And here we have a very decreased rotation to the left. So we have a decreased range of motion in two areas. We have the upper cervical issue and we have the lower cervical issue. And again, I cannot exclude that we have thoracic, lumbar, and sacroiliac joint. We just don't have time for all these examination issues. I always prefer the supine position on the couch, but here, of course, we have a chair. We shall do the best that we can here. You can palpate the atlas. You then palpate the second cervical, and you can do your palpation alongside the cervical spine in order to locate which vertebra is the pain generator, because this is what we expect to find somewhere. So actually I don't expect to be the atlas because there is a big difference. Usually the atlas is causing a very little difference in the movement. Do you have different feeling when I'm pressing here?
Yeah, it's a little bit more painful.
Here is more painful, okay. Then we go lower. This is the C2. This is the right side and this is the left side. Is it different? Right and left?
Not too much.
Not too much. Okay, we go to the C3. This is the C3. Here is very stiff actually.
Yeah, a little bit more.
Yeah, here is very, very stiff. The C2 and C3 are very stiff. And I will try to check again. So this is the limited range of motion, and this is the good range of motion. Oh, this is typical when we have a dysfunction in the upper cervical spine, and it is on the left side. And then for the lower part, if I make the local palpation, do you have any pain here?
Yeah.
This is the horizontal trapezius muscle. If I go like this, if I try to mobilize the vertebra, do you have pain?
A little bit, yeah.
A little bit, yes. If I do the same on the opposite side, like this. Oh, this is soft here. So it is here in this area.
Yeah.
Okay. So we have to work here on the left side, and then we shall check how the range of motion is involved, because so far our idea, the clinical idea is we have the so-called somatic dysfunction. We have a muscle spasm in the deep muscles of the neck, and the problem is more or less here on the second, third cervical on the left, and here we have the 6th, 7th cervical again on the left side, with some irradiation here in the horizontal trapezius muscle. Do you have any feeling here around the shoulder?
No, not necessarily. Still too good.
Okay, so if I'm in my office, I will write down these findings, and then we shall start to work with the device. Here we can use the manual scanning with the handpiece, or we can use the Charlie because we have it here. With the Charlie, you have to position it. I mean, here it's going to cover the whole area because we have a 5 centimeter diameter, so we can position it to work on the upper here area where we have two vertebrae that are painful, and then we can position it here in the lower part. And if I use the Charlie, I will probably make another one here directly on the horizontal trapezius. So I will cover 3 fields here on this side. I think that it's easier, because I have to undress him for the Charlie, to work with the manual handpiece. So I will do some manual scanning, and then we shall proceed with the point-by-point work. So I will give you back the glasses. Although in this case, actually you're working on areas that the patient cannot see. I mean, we're working here, here, here. But still, according to the rules, the glasses are important. For how long do you have this pain? For how long do you...
It comes and goes. Probably had it for like 3 to 4 months.
And now this situation, how do you feel it? For how many days you have it?
3 or 4 days. I might do some work, manual therapy on it. I might go, and then I might go to the gym and sort of recur.
We go to the neck, and this time here we have these possibilities. We have acute pain, chronic pain, we have scan phase, and we have trigger points. So we can either go above and pick one of the protocols, or we can choose one of these conditions. Here he's saying that it is relapsing, it is coming and going and coming and going. So it is chronic. But on the other hand, he has some experience with the gym. He has some, so it's very difficult to guess here at first, is it chronic or acute? So we can start with, let's say we start with acute, and we shall go to scan phase. And you see here, it's a very good actually starting protocol. The device is suggesting 300 Hertz, 3 minutes and 30 seconds with 25% in intensity. So this is a good way to start with this patient, because we have no other additional information. We don't have any imaging result. We don't have an X-ray. We don't have an MRI. And so far, we have only these functional problems. It is not a neurological patient. So this is a good starting point. And I have to come here back. Sorry for this. And now we start the scanning modality. And we're going to do this for 3.5 minutes. So I just need a little bit more space. I keep this as perpendicular as possible. Just a moment. Okay. You have this beeping sound, so the machine is saying to you, careful, I'm ready to start working. And you start. And I'm scanning alongside the cervical spine. I start at the level of the second cervical, and I go lower down to the 7th one. If I'm working in my office, I would have undressed the patient because the shirt is a little bit obstructing my work. And when you're scanning, it's good to do a little scanning on the other side also, especially about the cervical, the vertebral column. I always give 25% of the scanning on the other side also, because the idea of the scanning is to activate the tissues, and it's not good to give all of the energy on one side. So if we say that we have 3.5 minutes, I'll probably leave the last 45-50 seconds to the right side. So I'm not in a hurry. I do it very gently. I don't put so much pressure on him. And here in the neck, we are expecting a direct effect because we have a 3.5 centimeters penetration depth, which for these structures is absolutely enough. The handpiece is very light, which is very important, and the cable is not rigid, which makes your movement very easy. This is something also very important. So the scanning, you can perform it like I'm doing alongside, or you can do it like this. It depends, or you can combine both of them. And whenever you like, if you press the button, you're causing the device to stop. So you have a pause. It keeps on the settings here. So if for some reason you have to make a pause, you just press the button of the handpiece and it stops. It's very, very easy to operate. It's also very easy to teach somebody who works with you, who is a part of your team. After you make the examination, the evaluation, and the prescription. So now I'm going to stop and I'm going to move to the other side because I want to give some of the energy also to the right side. So what I'm expecting. Here in the upper side I have no problem. I work very easy and I know where is the area of the problem. Here in the lower part I haven't checked the thoracic spine, so normally I would have checked the thoracic spine. So if he has the same problems here lower in the upper thoracic part, probably this issue here will not be 100% resolved. It's very important to address as many problematic points as possible. You can see the protocol that the device is suggesting. It's 100 Hertz, 0, 0, 20, this is 20 seconds, and 25% intensity. Here, because I'm very short on time, I will go for the 10 Hertz. I will decrease even more the frequency. So this is a good situation, and I'm going to put the 23 seconds. This is a recommendation based on a lot of practical use of the machine. So this is what I would pick up for now. And now we shall check again. So here I need to palpate again. Just a moment. Here the left side is painful, yes? Mm-hmm. Okay, so here we can work. This is the transverse process of the atlas that I'm palpating. And then I go to the C2 here, also painful.
Not too bad.
And the third one is stiffer, here, this one. So we have probably, this is the atlas and the third cervical. I'm going to work on all of them. So in general, when you work on points, you have two opportunities. You can stay on the point and do this combination 2-3 times in a row, or you can do it once and then you can do it left, above, right, and below. And this way, I call this the flower. So you make a hit directly on the point and you work on all the surrounding tissues. In the cervical spine, because the area is very slow, is very little, I cannot make the flower here. I just don't have enough time. So I'm going to work directly on the point. So I will start with here working above. And I'm going to repeat this 3 times in a row. Here you're just maintaining the contact. You don't need to move anything more. And it's always to control the patient, to have some contact. Okay, now I go to the second one. So I have here another place that I have to work. Is the second cervical here. The level of the second cervical is easy to find because when you follow the central line for above, the first spinous process that you palpate, it is the second cervical. This is the way that you find it. And then you can count below the third, the fourth, the sixth. And actually now I'm working in the projection of the intervertebral joint. This is where usually this limitation of the movement is happening. And what I'm waiting here is the muscle spasm to be relieved by the MLS so that we gain back the initial range of motion. We should go back to the normal situation. If we don't achieve it, despite our efforts, then we have to start considering some structural situation, some structural problem. Especially in the cervical spine, if I don't have a improvement in the first 3 sessions, I always send the patient to the X-ray. This is the first step, because you need to be sure that there is not if you have a structural barrier, a structural limitation, you cannot expect to restore the range of motion. Of course, having in mind that he's a young person. How old are you?
32.
So okay, it's a young person. You didn't have any traumatic injury in the last years? You didn't have
this neck was like not super traumatic, but I couldn't turn my head really for 3 days.
Aha.
Yeah.
And what was the reason? Did you have some hit on the head, some blow, some car accident?
Previous to that, I was just telling over here, my car automatically braked thinking I was going to hit a car going around a bend, and it gave me sort of like whiplash.
It's a whiplash injury. I had a case of whiplash injury, very good case.
Sorry?
I had a case prepared, but I couldn't show it to you, whiplash injury. Yeah. Because we were focused on the sports traumas today. Although, for some criteria, the whiplash could be considered a sport injury, because all of the drivers, all the sports associated with driving, they have whiplash injuries. So you can ride the Ducati and have a whiplash injury. So it depends. It could become a sports trauma very easy. Now I'm going a little bit lower, and when I finish here, I'm going to check again the movement. This point, the transverse process of the atlas is painful anyway. So usually it is suggested to press both sides and ask the patient, is there a difference between, because if you press just the left side, you say, oh, it's very nasty feeling, but actually on the other side it's also not very pleasant. It's a very tender area. So where you're palpating a tender area, in order to find the difference, you need to palpate both sides simultaneously and ask the patient, what do you feel about it? How do you feel about it? We're going a little bit lower. I want to cover all the lower cervical. Here again, the chances of success are lower, because normally we would have covered here the whole horizontal trapezius, and we should check the upper thoracic also. But if we are lucky, if he has a dysfunction just in the lower cervical, we may be good enough. And this is the principle that you can follow in any patient. I mean, you start with the scanning. It's usually to be as not just one-sided, to give some 20-25% to the other side also, and then you follow the points. And here in this case, I would check also alongside the nerves, especially if he said in the history that sometimes he has some feeling in the hand, then probably I will find some tender points alongside the ulnar or the radial nerve. And these points, if we treat them, then it is very, very effective treatment. How is there a difference between the left and right side?
Nowhere near as painful as well as before.
You see what?
Yeah, less painful. Yeah.
Less painful. Okay. Now we check the movement. This is very important. Just a moment. I first want to palpate. Yeah, this is now definitely softer. Now let me check. We make a complete flexion, and now we make the rotation to the right. And now it seems completely the same, the left and the right. And just to remind you, it was up to here. So we have gained back the range of motion. In this situation, because he doesn't have very strong pain, now we're going to check the lower cervical. This is the area that I told you we have a lower chance of success. So we have the rotation to the right, and we have a rotation to the left. So here we also have a very good improvement. Here a little bit less we have to the right side, but here we have probably say 70-80% improvement in the range. There is a very minor difference between the left and the right. I'm sure that if I work a little bit lower, if I can work here the TH1, 2, 3, we shall be 100% successful. And this is a very good example actually, because most of the doctors who are not focused on the function, what are they going to do? They're going to prescribe myorelaxant medication, non-steroids. They can prescribe something for local treatment. So he is having a burden taking pharmacology that he probably doesn't need at all. And of course, this will take time. And very often, while they take this pharmacology, they are feeling fine. But at the end, if you don't restore the range of motion, he'll be back to this condition, and this can go long and long and long. And in Varna, I have patients. Usually, nobody comes first to my practice, because I don't work with the national insurance. I work only with private patients, so they have to pay from their pockets. The state is not covering my work. So they always try the family doctor, then they try some other doctor. And when they come to me, they have seen 3, 4, 5 doctors before. And I'm enjoying all the different diagnoses put by the colleagues. Most of them, I'm sorry to say, wrong. And then I examine my patients and I prescribe. In the Burgas hospital, I have the same device. I have this the MP75.5. And because it's a new hospital, I've been working there for 1 year. And it was built, it's brand new. It started in April the previous year. And I have taught my doctors, I have 2 female doctors, and they enjoy this device because they are very skinny and they are not so keen on working some manual adjustment or something like the manual therapy. They don't think it's good for them. But actually I showed them that with the laser you can achieve the same restoration of the range of motion, and they use the laser non-stop. I mean, now if I have to work on one of my patients, I usually call the head nurse and I ask, is the laser free? Can I go? Because I say, okay, Dr. Ruseva is there, but she'll be out in a couple of minutes. Thank you very much. So they are now fighting who is going to work with this, because you see, it is very easy. It's very gentle. You don't need to make a massage. You don't need to have some deep tissue treatment. You don't need to make manual adjustments. Plus, in order to be good in the manual adjustments, you have to study a lot. I mean, it's a long process. And how to work with the MLS, you can run for a couple of days.